Friends, today we are going to learn about healing of oral wounds. In this, we will learn first about the general factors which are affecting the healing of oral wounds, which are location of wound, physical factors, circulating factors, nutritional factors, age of the patient, infection, hormonal factors, and some others. Location of wound. Wound in an area which has a good vascular supply heals more rapidly than wounds in a relatively avascular area. So, we can say if an area is having good blood supply, then it will heal faster as compared to an area which is having less vascular supply. Similarly, wound in an immobile area heals faster than wound in a mobile area. If an area keeps on moving, then the healing will be slower. Physical factors. Trauma. Severe trauma to tissue delays wound healing. Mild traumatic injury favors healing. If an area is having severe trauma, then healing will be delayed. And the trauma, if is mild, very less, then it will favor healing. Local temperature. In environmental hypothermia, wound healing is accelerated, and while in hypothermia, it is delayed. Effect of X-ray radiation. Low doses of radiation tend to stimulate healing. Large dose of radiation or total body radiation tend to suppress the healing. Circulating factors. Anemia is reported to be responsible for causing delay in wound healing, and dehydration also affects healing adversely. Nutritional factors. First of all, let's read about proteins. Poorly nourished patients, due to low protein intake, exhibit delay in appearance of fibroblast as well as decreased rate of multiplication of fibroblast in the wound, thus delaying the healing. Conversely, it has been shown that feeding a high protein diet to animals will increase the rate of fibroblastic proliferation and cause the wound heal more rapidly. Vitamins. Vitamin C affects wound healing. It acts through regulation of collagen formation and formation of intercellular ground substances of the connective tissue. Vitamin A deficiency retards healing. Riboflavin and pyridoxine deficiency also results in a delay of healing process. Age of the patient. A wound in younger patients heals more rapidly than a wound in elder patients due to general reduction of rate of tissue metabolism. Because with increasing age, the rate of tissue metabolism also decreases, which will lead to reduction in the speed of the wound healing. Infection. Wounds completely protected from bacterial infection heal considerably slower than wounds which are exposed to bacteria or other mild physical irritation. Severe bacterial infection slows down the healing process. Hormonal factors. ACTH, which is adrenocorticotropic hormone, and cortisone administration results in delay in wound healing. In diabetes mellitus, clinically evident retardation in repair of the wound occur, and also there is complication in the healing process due to disturbance in the carbohydrate metabolism at the cellular level in local area of the wound. So let's start with healing of extraction wounds first. Healing of extraction wound, there are 3 steps: immediate reaction following an extraction, healing of wound in 1st to 4th week, and radiographic changes in the healing socket. Immediate reaction following an extraction. After the removal of tooth, blood which fills the socket coagulates. Red blood cells get entrapped in the fibrin meshwork and the ends of the blood vessels in the periodontal ligament are sealed off. Hours after the tooth extraction, if blood clot is dislodged, healing may be affected and may be extremely painful. However, if the healing is normal, within 24 to 48 hours, there is vasodilation and engorgement of blood vessel into the remnants of the periodontal ligament, and there is mobilization of leukocytes to the immediate area around the clot. Surface of the blood clot is covered by thick layer of fibrin. Healing of wound in 1st to 4th week. Here, proliferation of fibroblasts from connective tissue into the remnant of periodontal ligament is evident, and these fibroblasts begin to grow into clot around the periphery. The clot is gradually replaced by granulation tissue. Epithelium at the periphery of the wound exhibit evidence of proliferation seen in the form of mild mitotic activity. The crest of the alveolar bone, which makes up the margin or neck of the socket, exhibit beginning of osteoclastic activity. Endothelial proliferation signals the beginning of capillary growth. During this period, blood clot begins to undergo organization by ingrowth of the fibroblast and occasionally by small capillaries from the residual periodontal ligament. An extremely thick layer of leukocyte gathers over the surface of the clot, and the edges of the wound continue to exhibit epithelial proliferation. Now, let's see what are the changes occur during the 2nd week of the wound. During this 2nd week, after extraction of the tooth, the blood clot is becoming organized by fibroblasts growing into the clot and forming fibrin meshwork. At this stage, new delicate capillaries have penetrated to the center of the clot, and the remnants of periodontal ligament have been gradually undergoing degeneration. The walls of the bony socket appear slightly frayed, and in some cases, trabeculae of osteoid can be seen extending outward from the walls of the alveolus. Epithelial proliferation over the surface of the wound is extensive. Margins of the alveolar socket exhibit prominent osteoclastic resorption. Fragments of necrotic bone are seen in the process of resorption or sequestration. 3rd week wound. In 3rd week, the original clot appears almost completely organized by maturation of granulation tissue. Very young trabeculae of osteoid or uncalcified bone are forming around the entire periphery of the wound from the socket wall. Early bone is formed by osteoblasts derived from pluripotential cells of the original periodontal ligament, which assume osteogenic function. Original bone of alveolar socket undergoes remodeling so that it no longer consists of such a dense layer. Crest of alveolar bone have been rounded off by osteoclastic resorption, and by this time surface of the wound may have become completely epithelialized. Changes during the 4th week of extraction. There is continuous deposition, remodeling, and resorption of the bone filling in the alveolar socket. Due to this, crest of the alveolar bone undergoes considerable amount of osteoclastic resorption during the healing process, and because of this, bone filling the socket does not extend beyond alveolar bone crest. Radiographic changes in healing socket. A tooth having been removed and after variable and unspecified length of time, there is gradual loss of lamina dura, and at the same time bone develops at the base and sides of the socket. By the time that the socket is filled with bone, all traces of lamina dura is gone, and later the new bone consolidates and comes to resemble the adjacent bone. Most healed socket reveal slight or marked cortical bone formation at the surface of the alveolar process, and following the removal of tooth, the alveolar margins undergo some resorption. The surface usually becomes flat or slightly curved but smooth. Healing of biopsy wound. Biopsy is the removal of tissue for the purpose of microscopic examination and diagnosis. It occurs in two steps: primary healing and secondary healing. Healing by primary intention or healing by first intention is that type of healing which occurs after excision of a piece of tissue with close apposition of the edges of the wound. When the edges of the wound are brought together into contact and held in place by sutures, the blood clots, and in a matter of hours, numerous leukocytes are mobilized in the area. When the connective tissue cells in immediate vicinity undergo transformation into fibroblasts, which in turn undergo mitotic division, new fibroblasts begin to migrate into the across the line of incision. These cells form thin, delicate collagen fibrils which intervene and coalesce in a general direction parallel to the surface of the wound. Endothelial cells of capillaries begin to proliferate and small capillary buds grow out across the wound. These buds eventually form new capillaries which will fill the blood, and rich network of young capillaries and capillary loops are formed. Coming to the secondary healing, it occurs when there is a loss of tissue and the edges of the wound cannot be approximated. In primary healing, the edges of the wound can be approximated and there is no loss of tissue. For example, palate or alveolar mucosa, etc. The material which fills the defect in secondary healing is called granulation tissue. The gap which is made is filled by granulation tissue. After the removal of lesion, blood clots and the repair process begins. Cellular proliferation begins around the periphery of the wound, and fibroblasts and the endothelial cells grow into the clot along the fibrin strands. In addition, polymorphonuclear leukocytes, mononuclear phagocytes, and later the lymphocytes migrate into the granulation tissue from the adjacent vessel and tissues. Large number of leukocytes also accumulate on the surface of the wound. As granulation tissue matures, it becomes more fibrous through condensation of collagen bundles, and the surface of the lesion become epithelialized and the lesion become somewhat avascular. Secondary healing is basically identical with the healing by primary intention, except the fibroblast and capillaries have a greater distance to migrate and more granulation tissue must form. Healing is slower. You can say these are the difference between primary and secondary healing also. Till now, we have learned about healing of extraction wounds and healing of biopsy wounds. Now, let's study about healing of fractures. Let's learn about immediate effect immediately after the fracture. After fracture, eversion vessels of the bone, vessels of periosteum, marrow cavity that happen to cross the fracture line are torn at the fracture site. Due to disruption of vessels, there is considerable extravasation of blood in that area, but at the same time there is loss of circulation and lack of blood supply. The bone cell or osteocytes of eversion system die due to tearing of vessels at the fracture site, and there is death of bone marrow adjacent to the fracture line. The blood clot which forms plays an important role in healing of the fracture through replacement by granulation tissue and its subsequent replacement by bone. After that, callus formation occurs. So let's learn about callus formation. Callus is a structure which unites the fractured ends of bone and is composed of varying amount of fibrous tissue, cartilage and bone. There are two types of callus, external callus and internal callus. External callus. External callus consists of new tissue which forms around the outside of the two fragments of the bone, and internal callus consists of new tissue arising from the marrow cavity. This is the main difference between external and internal callus. Periosteum is an important structure in callus formation and ultimate healing of fracture. Cells of periosteum torn at the fracture line usually die. Due to peripheral to the area is found a flurry of cellular activity within hours of injury. Outer or fibrous layer of periosteum is relatively inert and actually lifted away from the surface of the bone by proliferation of cells in osteogenic or inner layer of periosteum, which assumes features of osteoblast, begins the formation of small amount of new bone. There is continuous proliferation of these osteogenic cells forming a collar of callus around or over the surface of the fracture. New bone which begins to form in the external callus usually consists of irregular trabeculae laid down at right angle to the surface. This differentiation of cells into osteoblast and subsequent formation of bone occurs in the deepest part of the callus collar, and new bone which begins to form in the external callus usually consists of irregular trabeculae laid down at right angle to the surface. In the rapidly growing area of collar bone, varying number of cells of osteogenic layer differentiate into chondroblast rather than osteoblast and actually form cartilage. This cartilage fuses with bone and then begins to calcify by endochondral bone formation, and the calcified cartilage is gradually resorbed and replaced by bone. Internal callus forms from endosteum of Haversian canal and undifferentiated cells of bone marrow. Shortly after the fracture, endosteum begins to proliferate within a week to form new bone, and which gradually unite and establish the continuity of the bone. After this, both external and internal callus remodel to form indistinguishable bone. So, this is how the fracture wound is healed. Thank you for watching my video. Friends, if you like my video, please subscribe my channel and ring the bell icon for latest updates.